Today, we're going to be addressing the question current treatment options and things to consider for myelofibrosis patients with Dr. Anand Patel. This topic was chosen because it's important to understand not only what treatment options are available for myelofibrosis, but how to find the right approach for your care. I'm going to take a moment to introduce Dr. Anand Patel. Dr. Anand Patel is a board certified hematologist oncologist and an expert in treating myeloproliferative neoplasm diseases, myelodysplastic syndromes, as well as leukemias. He also serves at the NCCN panels for AML and MPNs. Dr. Patel's research interests are geared towards development of clinical trials that help improve the standard of care for patients with high-risk leukemias and myeloid malignancies. In 2024, Dr. Patel was named to the 40 Under 40 in Cancer, an award that recognizes him as one of the nation's most promising young oncology professionals and celebrates his contributions to improve the lives of those affected by cancer. We are thrilled to have Dr. Patel with us today, and with that, I'm going to turn the time over to you, Dr. Patel.
Thanks so much, Dalton, for that very kind introduction. And thanks to everyone in the audience who's joining me today. So, as mentioned, my name is Anand Patel. I am an assistant professor of medicine at the University of Chicago. And in practice, I predominantly see patients with MPNs, along with acute leukemias and myelodysplastic syndromes. So over the course of the next 30 minutes or so, really what I want to focus on is talking about our current treatment options in myelofibrosis, and then really thinking about what is the right approach for an individual patient. Because choices are great, but with choices also come the consideration of what drug may be the best option for me versus some of the other therapies that are out there. These are my disclosures. And I will be talking about drugs that are both FDA approved. I will talk about some promising clinical trials as well that will be discussing drugs that are not yet FDA approved, but have shown benefit in myelofibrosis. So I will make sure to designate which bucket each of those therapies falls into over the course of this presentation. So I wanted to lay out some objectives, and I want to start by providing a general overview of MPNs, the disease states that kind of fall within MPNs, how we think about progression of MPNs. Next, I will talk about prognostic scores in myelofibrosis. So myelofibrosis is very heterogeneous. You have patients with myelofibrosis that can live with it for years and years and years without treatment. There are patients who are quickly requiring something like a stem cell transplant after being diagnosed with myelofibrosis. So using prognostic scores to identify which bucket of risk someone's disease falls into is a very important part in the management of myelofibrosis. And then lastly, I'm going to talk about standard treatment approaches in myelofibrosis, when to think about allogeneic transplant, and what novel therapies have been studied more recently in myelofibrosis. So when thinking about MPNs, there are many different types of MPNs, but the three most common disease types are polycythemia vera, which is characterized by a high hemoglobin and hematocrit, and almost all patients have a mutation in the gene JAK2. You have essential thrombocythemia, or ET, which is characterized by an elevated platelet count, the blood cells that allow for clotting, and patients will have either a JAK2 mutation or a mutation in one of two other genes called CALR or MIPL. A small percentage of patients will be what we call triple negative, meaning they do not have a mutation in any one of these three genes. And then we have primary myelofibrosis. So primary myelofibrosis can have variable blood counts based on when someone is diagnosed. In the cellular phase of disease, blood counts can actually be high. As the fibrosis or scarring of the bone marrow progresses over time, blood counts can become normal and then drop into the low range. Much like ET, patients will have mutations in either JAK2, CALR, or MIPL, with a small percentage having triple negative disease, meaning no mutations in any of those three genes. When thinking about disease progression in MPNs, really, there are two progression events that we worry quite a bit about in terms of the disease itself. There's the progression to myelofibrosis, which can happen in patients who have primary myelofibrosis, reaching what we call the fibrotic stage of disease. Patients with PV and ET um, can also develop what's called secondary myelofibrosis, meaning their disease has progressed from having these high blood counts, whether it's the elevated hemoglobin, whether it's the elevated platelets, and there has been increased scarring that has then led to the diagnosis of secondary myelofibrosis. The other thing we worry about is progression to what we call the accelerated or blast phase of MPNs, which is when the MPN starts behaving less like a chronic or slow-moving blood cancer and starts behaving more like an acute leukemia and is more aggressive in its progression of disease. I do want to spend a little bit of time talking about how we diagnose myelofibrosis, because honestly, that's how the most critical part of many patients' journeys is arriving at the correct diagnosis, which can then allow for the appropriate treatment plan to be formulated. It is absolutely essential to get a bone marrow biopsy as part of the diagnosis. You're going to want to rule out any other myeloid cancers or other types of white blood cell cancers. There needs to be evidence of this being a cancer, meaning there needs to be either a specific gene mutation or some other clonal marker, meaning the cells we're seeing are truly cancer or MPN cells. And then there are some minor criteria. So you need to have either a low hemoglobin, an elevated white blood cell count, the spleen needs to be large, LDH, which is a marker of cell turnover, or leukoerythroblastosis, which are characteristic findings seen on a peripheral blood smear in someone with myelofibrosis. So patients typically need 3 major criteria and 1 minor criteria to arrive at a diagnosis of myelofibrosis. And when thinking about how we risk stratify patients with myelofibrosis, our tools have become increasingly refined over the last 15 years or so. So the first tools that were designed were called the IPSS and the dynamic IPSS that largely relied on clinical markers, meaning what's your blood count, are there blasts or immature cells in the blood, what sorts of other blood count issues are you seeing? And then we found that if you layer additional information on top of clinical features, whether it be cytogenetic information, so information about the chromosomes of the myelofibrosis cells, or molecular information, meaning are there what we call high-risk mutations present within the myelofibrosis cells, we found that we could increasingly refine our prognostic tools. So currently, I would say our prognostic scores are in the molecular era. So if you look at the last several scores that have been developed, all of which kind of cluster around 2018, you can see they all incorporate some degree of molecular information. There have also been follow-up studies to show that perhaps we need to expand the list of so-called high-risk mutations. There may be other mutations that confer increased risk of someone's myelofibrosis progressing and therefore needing more aggressive intervention. So how do we risk stratify and then think about the management of a patient with myelofibrosis? We first look at the clinical risk score. So for patients with low or intermediate 1 risk disease, if they don't have high-risk mutations, if they don't have symptoms, those patients can undergo what we call active surveillance. They do not necessarily need to initiate treatment right at that time point. On the other hand, for patients with a high clinical risk score, the presence of high-risk mutations, or with symptoms, we should be thinking about starting a JAK inhibitor, and we'll talk about the 4 approved JAK inhibitors in great detail today and what they do. You should be thinking about clinical trial strategies if appropriate. And in patients who are well enough to receive a allogeneic transplant, you should be considering a referral for that patient to be evaluated for a transplant. 2 other points I want to make. Not all patients with myelofibrosis need treatment, and supportive care, meaning things like blood transfusions if your counts are too low, being on appropriate medicines to help prevent infection if your white blood cell count is too low. These sorts of things are an essential part of myelofibrosis management. The 4 approved JAK inhibitors are ruxolitinib, fedratinib, pacritinib, and momelotinib, and these are listed in the order by which they were approved. So ruxolitinib has been approved for about a decade at this point. Fedratinib has been approved for about 4 years or so, pacritinib about 2 years, and momelotinib just over 1 year. So let's talk about how these specific JAK inhibitors have been approved for myelofibrosis. And I'm going to focus on ruxolitinib first. So ruxolitinib was approved based on a study called the COMFORT-1 study. And this looked at patients with intermediate or high-risk myelofibrosis. They had a palpable spleen, meaning on physical exam, a physician or someone else could tell that the patient had a large spleen. The platelet count had to be over 100, and there needed to be less than 10% blasts or immature cells in the blood, meaning that these patients were not in the accelerated phase or blast phase of disease, but what we call chronic phase myelofibrosis. And the primary endpoint, meaning the study's main objective, was to determine, is ruxolitinib better at shrinking the spleen by greater than 35% than placebo? And what was found was in the patients treated with ruxolitinib, about 40% of them had the requisite reduction in spleen size. And when you look at the placebo group, virtually no one had that response. So ruxolitinib is very good at shrinking the spleen and does that in about 40% of patients at the threshold of 35% or greater in patients who need a JAK inhibitor that have not previously been on one. The COMFORT-2 study was a very similar study, except instead of comparing ruxolitinib to placebo, it was compared to what we call best available therapy, or BAT, meaning investigators could use whatever therapy they thought was best for the patient at that time, which could be things like steroids or medicines to help stimulate blood counts, or other kind of medicines that were thought to be reasonable in the use of treating myelofibrosis. And again, what was found was that there was a significant benefit in the patients who received ruxolitinib compared to best available therapy. In this study, about 30% of patients met the endpoint of reduction in spleen size. The other thing to note is if you take away that kind of characterization of needing the spleen to shrink by 35% or more, if you just look at any shrinkage in the spleen, 97% of patients on ruxolitinib had at least some shrinkage in their enlarged spleen. Some practical considerations about ruxolitinib. The main side effect we see with this drug is it can reduce your blood counts, whether it be your hemoglobin or your platelet count. And because of that, there does need to be some consideration about what dose to start at and then how to adjust that dose if needed. We have data to support that you can start at a middle dose of ruxolitinib, 10 milligrams twice a day, and then increase it to the maximum dose if needed, if the symptoms and spleen are not controlled. We also have data to show that if you're getting 5 milligrams twice daily of ruxolitinib or lower, you're probably not getting a high enough ruxolitinib dose for it to be effective. So this is very important because many times if patients are on ruxolitinib, they start developing low blood counts related to ruxolitinib. The first step oftentimes is reducing the dose of ruxolitinib and seeing if that will help. If the dose reductions put you at a dose of 5 milligrams twice a day or lower, there probably needs to be consideration about what medicine can we switch to other than ruxolitinib, because a dose that low is unlikely to be providing significant benefit. The next JAK inhibitor I'm going to talk about is fedratinib, which was looked at in a few different studies. The first study was called Jakarta, and this looked at the use of fedratinib in patients who had not been previously treated with a JAK inhibitor, and it was compared to placebo and 2 different dosing strategies of fedratinib. The primary endpoint, much like the ruxolitinib studies, was reducing the spleen size by 35% or more. So only 1% of patients achieve this in the placebo arm, and about 40% of patients achieve this in the two different fedratinib doses. Ultimately, the dose of 400 milligrams of fedratinib was thought to be the one that best balanced effectiveness of reducing the spleen while also reducing potential side effects associated with fedratinib. The other major study for fedratinib was a randomized study called the Freedom 2 study. So the very important thing about this study is it specifically looked at patients who had been previously treated with ruxolitinib. So patients with myelofibrosis who had previously received a JAK inhibitor, specifically ruxolitinib. And this study then wanted to characterize, does switching from ruxolitinib to fedratinib offer a benefit to patients? And what was found was the answer was yes. So if you take patients who are on ruxolitinib, they are no longer having a response or they're having excess toxicity from ruxolitinib, and those patients are then switched to fedratinib, about 35% of patients will have a significant reduction in their spleen size. So this helps to kind of demonstrate that fedratinib is not only an option for patients who have not ever been treated with a JAK inhibitor, but it's also an option for patients who previously received ruxolitinib and now need to switch to a different JAK inhibitor for one reason versus another. The next JAK inhibitor is pacritinib. And pacritinib is specifically one that is approved for myelofibrosis with low platelets. And we'll talk about why that is over the next couple slides. So PERSIST-2 was another study looking to seek and determine the benefit of pacritinib. And what was the eligibility criteria are very similar to what we've seen in other studies. So intermediate or high-risk disease, splenomegaly, meaning an enlarged spleen, a high symptom burden. Specifically for this, platelets needed to be less than 100,000. So the investigators were specifically looking to establish the benefit of pacritinib in those with low platelets. They had to be in the chronic phase of myelofibrosis, meaning less than 10% blasts, and patients could have been on a JAK inhibitor previously. So some of these patients had gotten ruxolitinib before going on this study. Now, this study looked at two things as their primary endpoints. Not only did they want the spleen size reduction, they also wanted a reduction in symptom burden by 50% or greater. And I think this is very important. Shrinking the spleen doesn't mean a whole lot by itself if patients are not feeling better when that's done. And if you look at the middle column, which is the dose of pacritinib that is now standard and what we use as an FDA-approved dose, 200 milligrams twice a day, about 13% of patients achieved the endpoint of a spleen reduction, and about 32% of patients achieved the endpoint of symptom reduction. When you look at patients with platelets less than 50, so a very low platelet count, those numbers actually hold up pretty impressively. So about 30% of patients had a spleen reduction, and about 23% of patients had a 50% reduction in their symptom burden. There's also a study called Pacifica that is ongoing that's looking at specifically only enrolling patients with a platelet count of less than 50,000 to either pacritinib or a physician's choice of treatment. And it's looking at those same endpoints: spleen volume reduction, or SVR, and total symptom score reduction. So pacritinib is currently approved for myelofibrosis in patients with a platelet count of less than 50,000 that need to be on a JAK inhibitor. And this study will hope to confirm that benefit in a larger trial setting. And now let's talk about momelotinib, which is our fourth JAK inhibitor. So the Momentum study was a study looking at patients with myelofibrosis who have a low hemoglobin, otherwise known as anemia, and who had previously received a JAK inhibitor. So momelotinib has specifically been developed to address the need of myelofibrosis and anemia being present together. So the Momentum study looked at Momelotinib versus a drug called danazol, which has previously been used to help improve hemoglobin levels in patients. And the endpoint here was a reduction in symptom burden. So they did not actually specify the spleen reduction as something that had to be seen. The main thing that was looked at was reduction in symptoms. And they did look at several other things. So when thinking about symptoms, about 25% of patients felt better compared to only 9% on danazol. When looking at transfusion independence, meaning patients no longer needing blood transfusions on a regular basis, about 30% of patients on momelotinib achieved that versus only 20% on danazol. And then when you look at spleen response rate, so a reduction of 25% or more, 40% of patients with momelotinib achieve that versus only 6% on danazol. So momelotinib compared to danazol made patients feel better. It made patients less reliant on transfusions, and it shrunk the spleen. This is another way of kind of demonstrating that and really demonstrating that the vast majority of patients on momelotinib had a reduction in their symptom score and had a reduction in their spleen volume. So it does seem to benefit both aspects of the disease in a pretty significant way. One general thing to note, if you or a loved one or someone else that you know with myelofibrosis is on a JAK inhibitor, there is an entity called JAK inhibitor withdrawal syndrome that has been well described. So if patients are on JAK inhibitors and they are stopped abruptly or suddenly, patients can have rapid progression of their symptoms. They can feel like the spleen is enlarging very quickly. They can feel flu-like. So, with that in mind, if you're seeing another physician and there's consideration being given to stopping or holding the JAK inhibitor, that should be done in very close collaboration with the physician managing myelofibrosis, because the JAK inhibitor should ideally be tapered, meaning slightly lower doses over a period of time, or sometimes you can use steroids for a short amount of time to help prevent these symptoms. So, we have 4 options, and how do we pick them? In terms of what the best JAK inhibitor is for a specific patient. This was a very nice review article that was just published earlier in the year by Dr. Masarova, who's a myelofibrosis expert at the MD Anderson Cancer Center. And in my mind, I think it really nicely illustrates what the best area for each of these different JAK inhibitors is. In my mind, the preferred JAK inhibitor continues to be ruxolitinib. It's the JAK inhibitor with the most data behind it. It's been approved for 10 plus years. And if patients don't have low blood counts that would prevent the use of ruxolitinib, it remains a very reasonable initial option, kind of what you see in the middle here. Now, if you have patients with either severe anemia or severe low platelet levels or thrombocytopenia, you can think about using either momelotinib or pacritinib ahead of ruxolitinib. And then the major place where fedratinib factors in my mind, is in patients who have previously been on ruxolitinib, who are no longer deriving benefit, meaning their spleen is starting to grow again after shrinking, their symptoms are getting worse, etc. That would be the patient in which switching to fedratinib may offer real meaningful benefit. Now, there are limitations of JAK inhibitors that I think are very important. So one is that the low blood counts or cytopenias can be dose limiting. They don't seem to eradicate the myelofibrosis cells in a meaningful way. JAK inhibitors don't seem to prevent the rate of progression to blast phase or AML. And if you look at patients who are on JAK inhibitors for a long period of time, 5 years or so, if you follow them, about 70% of patients ultimately stop their JAK inhibitor for one reason or another. So JAK inhibitors are a very important advancement in myelofibrosis, but I think it's important to note they make people feel better. They shrink the spleen, but it is unclear if they are meaningfully kind of controlling or eradicating the underlying myelofibrosis. With that in mind, what about allogeneic stem cell transplant? So the timing of transplant is a critical aspect of the management of myelofibrosis, and it is what I call a Goldilocks problem. Thinking about transplant too early in someone with low risk or low grade myelofibrosis may ultimately mean that someone is being considered or undergoing a transplant that they may not need for several years. On the other hand, in patients who have very advanced myelofibrosis, there may come a time where they are too sick to receive a transplant safely, or their spleen is too large, which makes it unlikely that the transplant would be successful. So you really are looking for that just right window of allogeneic transplant. So there are several things that need to be considered when thinking about transplant. I really like this diagram and how it kind of breaks them into buckets. So thinking about age, and I want to stress there is no magic age at which transplant is no longer an option. It's really individualized for each specific patient. You then have to think about what other medical conditions does a patient have. Next, you think about, is their spleen enlarged? Are there other disease features that make the transplant more high risk? For example, blood clots or very low platelets? Are there high risk mutations that could make it such that the transplant is unlikely to work? And what treatments has someone already been on? So you can see transplant is a decision making process that takes a lot of different data points. And most importantly, the patient's preferences and voice into ultimately what the right thing to do is. I would say meeting a transplant doctor early in someone's myelofibrosis journey is never a bad thing, because even if transplant is not being recommended at that time, at least all of the necessary workup and discussions are ongoing. The other thing to note is while transplant is a potentially curative approach in myelofibrosis, it does not cure all patients with myelofibrosis. So if you look at the column noted survival, these are many different studies that have looked at allogeneic transplant and myelofibrosis. And in general, we think about somewhere in the neighborhood of 50 to 60% of patients being cured with a transplant. One of the really exciting things in myelofibrosis right now is we are starting to move beyond JAK inhibitors and identifying other targets that may be of benefit when thinking about novel drugs. Three that I'm going to talk about are BCL2/BCLXL, BRD4, and TERT, and the specific drugs that target these. So the Transform-1 phase 3 study, which was presented at our ASH annual meeting about a year ago, looked at patients with intermediate or high-risk myelofibrosis and randomized them to either receiving ruxolitinib, which is the JAK inhibitor I previously discussed by itself, or ruxolitinib combined with a drug called navitoclax, which is a BCL2 BCLXL inhibitor. And what was looked at was reduction in spleen size, along with a number of other endpoints, including improved symptom burden. And important things that were found in this study. The spleen response criteria was met. So about 60% of patients had a spleen reduction when they received the combination versus only about 30% of patients with ruxolitinib alone. Importantly, though, patients did not feel any better with the combination therapy versus ruxolitinib by itself. So reduction in spleen size, but no significant improvement in the symptom burden. The other thing is the combination therapy does have toxicity. So about 50% of patients developed grade 3 thrombocytopenia or low platelet count, and 40% of patients developed grade 3 neutropenia, which is a low white blood cell count that can put you at risk of infection. Ultimately, this disconnect, reduction in spleen size, but no improvement in symptoms, led to the fact that navitoclax likely will not be a standard option for patients with myelofibrosis. And I think really underscoring the fact that therapies need to make patients both feel better and reduce their spleen size in a meaningful way. The other phase 3 study that was presented at the ASH conference last year looked at the BET inhibitor Pelabresib in combination with ruxolitinib versus ruxolitinib by itself. And again, very similar design to the previous study I just mentioned with navitoclax, where the primary endpoint was reduction in spleen size, with a key secondary endpoint being total symptom score reduction. And spleen size, similar to the other study, about 65% of patients had a 35% reduction in spleen when they received the combination therapy, versus only about 35% of patients that received ruxolitinib by itself. When looking at symptom burden again, 50% of patients had a improvement in their symptom score by 50% or more, but a very similar amount had the same in ruxolitinib. So really seeing that same disconnect where spleen size is significantly improved when you get both drugs. You may or may not feel better when you get the combination versus the single drug by itself. And there are also side effects to be considered. So I will say the side effect profile of Pelabresib compared to navitoclax is more favorable. Pelabresib doesn't seem to reduce the blood counts in the same way, which allows for patients to tolerate it a little better. So long-term follow-up is still ongoing with this study, really hoping to determine, is there a long-term benefit to being on these two drugs together? And will this then inform potentially Pelabresib becoming a new FDA-approved option for myelofibrosis? And then the last drug I want to highlight is a drug called imetelstat, which is a telomerase inhibitor. And this drug is being developed based on a very promising phase 2 study that was reported out about 3 years ago in relapse refractory myelofibrosis. And one thing that's very interesting is this is one of the few studies that's looked at, do patients live longer and better potentially when they're on imetelstat? So if you look at patients who are on imetelstat, at the 1 year mark, about 84% of patients were still alive, and at the 2 year mark, about 58% of patients. And these were all patients that had been previously treated with their myelofibrosis. So all patients with myelofibrosis that was beginning to progress already. About 38% of patients had a reduction in spleen size, and about 32% of patients had a reduction in symptom score. There are adverse effects to be considered. Again, the major ones being low blood counts that you need to be watching out for. But these data have informed the development of a phase 3 study that's going to be looking at the use of imetelstat in relapse refractory myelofibrosis. And the endpoint of that study is overall survival. So this is the first study that's specifically going to be asking the question, does a drug make patients with myelofibrosis live longer compared to the standard approach? There are other phase 3 studies going on in myelofibrosis, and many of them are kind of using that approach of adding the new drug to ruxolitinib and seeing if it's better than ruxolitinib by itself. Those drugs are navtemadlin and selinexor, and I already mentioned the phase 3 study going on in relapse refractory myelofibrosis looking at imetelstat. I think one question that's been in our minds as a myelofibrosis community is spleen size and symptom the right thing to be looking at? Are there more specific markers that we can look at that would predict ultimately if drugs will help patients live longer and better? So some other things that are being considered are molecular response, meaning can we eradicate the mutations seen in the myelofibrosis cells? Do we see improvements in cytokines that drive the symptoms? Does reversing the fibrosis in the bone marrow matter, or does resolving low blood counts or cytopenia matter? So with that in mind, I think there's increasing thought about how do we reconfigure clinical trials to not just look at symptoms and spleen, but also think about overall survival or endpoints that allow for us to predict that a drug will also lead to improved overall survival. And this is something that no one party is going to be able to arrive at by itself. This is going to require input from our patients, the academic societies that focus on this, pharmaceutical companies that design these drugs, the clinicians taking care of patients, major societies like the American Society of Hematology and others, and the regulatory bodies that will ultimately approve a drug or not. So in summary, Cellular phase MPNs have a variable risk of progression to myelofibrosis. This can be teased out to some extent with the many prognostic scores we have available to us. Risk stratification is an essential part of treatment and transplant decision making. There are 4 FDA-approved JAK inhibitors, and each of which, in my mind, have a very specific slot. So there's ruxolitinib, which is the preferred first JAK inhibitor in my mind. You have pacritinib, which has been developed for myelofibrosis with low platelets. Momelotinib, which has been developed for myelofibrosis with low hemoglobin. And fedratinib, which has shown benefit in patients who have already been treated with a JAK inhibitor as a second JAK inhibitor. And then lastly, there are several novel therapies that are being investigated in myelofibrosis. And really, over the next few years, we may get a sense of what other treatments we'll have in our toolbox to help our patients live better and longer. So with that, I want to thank you so much for your time. Here's my contact information, and I'm happy to take questions.
Awesome. Thank you so much for that presentation. Um, that was incredibly informative. Again, now is the time for us to ask questions. So if you have any questions about current treatment options and things that you should be considering when looking at these treatment options for Dr. Patel, feel free to ask them. You can unmute yourself if you want to ask it verbally. You can also type a question in the chat and I will go ahead and read that out loud. So have a couple of different options for you. And then we understand if you need to hop off before the end of our time here. But as a reminder, you do have the opportunity to fill out that survey at the end. Again, that just helps us when we're trying to plan future events. So we would really appreciate if you went ahead and did that. But with that, let's hop into questions. So, first question here. Can you give us an update and info regarding the CalR targeted studies being done?
Yeah, I have very little to add because it's early days. So there are a number of different approaches, specifically looking at strategies in patients with myelofibrosis who have a CalR mutation, which is the second most common mutation seen in patients with myelofibrosis. So these are studies ranging from vaccine-based approaches to antibody-based approaches, even things like CAR T cell therapies being developed. But I would say we're very much in the early days where right now the studies that are ongoing are trying to determine the safety of these approaches and then if there's any signal for efficacy. So early days when it comes to CalR, I would say at this point.
So would those be considered like a phase 1B type
That
trial
yeah, so
or
so many of these studies are in the phase 1 portion, where really the goal of a phase 1 study is to determine what the right dose of a drug is, and is that dose safe? And that's kind of the point we're at. So when you think about phase 1, phase 2 being, are we seeing any signal for efficacy, meaning is the drug effective? And then phase 3 really being the confirmatory, is our novel or new drug better than the current standard of care? And I would say right now, most of these CalR approaches are still in the phase 1 bucket.
gotcha? All right, next question. What do you think about the use of interferon?
So um, I think interferon is very effective and a great tool in the management of MPNs in general. I would say the most beneficial area is in polycythemia vera and essential thrombocythemia. So once patients have progression of their disease to myelofibrosis, interferon seems to have a very limited role because it doesn't seem to meaningfully impact the spleen and the symptoms. Whereas when you use it, for example, in polycythemia vera or essential thrombocythemia, it helps to normalize the blood counts pretty regularly. And there may be some benefit where interferon might even reduce the risk of progression to myelofibrosis. So I think in the early treatment of MPNs, interferon is very reasonable and should be thought about. Once patients are in the myelofibrosis stage of things, I think its role is much more limited.
All right, next up, we have someone saying that they have a hematologist who's been treating them for PV for about 15 years, but they've now progressed to myelofibrosis. When do I get a second opinion on treatment? Also, I think that's a great, more general question of how does a person go about getting a second opinion?
Yeah, so I would say this is the time to get a second opinion. So when thinking about MPNs, overall they are a rare blood cancer. Even if you add up all of the different subset of MPNs, they still fall well below 40,000 new cases a year, which is how rare cancers are defined in the United States. I have the luxury, and many of my colleagues within the MPN community, of focusing and enriching my clinic with patients with these diseases, and it's something I'm passionate about treating. By the same token, it allows me to stay up to speed and up to date on all of the novel breakthroughs and developments that are happening. So in my mind, if someone is in the early stages of their MPN, polycythemia vera, ET, or even early myelofibrosis, as there's signs or evidence that the disease is beginning to progress into the fibrotic stage where blood counts are worsening, the spleen is getting larger, I would say that is the perfect time to be referred to a subspecialist, especially because I would say while we have standard options for myelofibrosis like the JAK inhibitors, we need to do better. So there are a lot of trial options that are available even in patients who have not previously been on a JAK inhibitor that you would have access to. Typically, getting referred to a subspecialist will also allow for that conversation about transplant to begin if appropriate. Um, and in terms of how to identify where to go get a second opinion, I mean, I would say the first step would be talking to your treating physician or hematologist and seeing if they have a subspecialist that they work closely with in terms of who they typically refer patients to if they have myelofibrosis. And Dalton, correct me if I'm wrong, but I think HealthTree has some resources in that vein as well. I'll let you jump in.
Yeah, we do. So HealthTree does have a or a specialist directory. So right now, I want to say it's only for patients within the United States, but the way that that one works is you can put in wherever you live and it'll pull up specialists for Alabama or for Utah or wherever you're at. So you can get a pretty clear list of not just hematologists, oncologists, but those who specialize in MPNs. So that's a really good resource when looking for a specialist. Um, and I did want to kind of have a follow up. It's not here in the chat, but I feel like a lot of people, when the conversation about getting a second opinion comes up, they're almost scared to offend their doctor. But getting a second opinion, that's a patient's right. And especially when you're dealing with a rare blood cancer like this, it's something that I think a lot of people should really take advantage of. Can you kind of help dispel that notion that asking for a second opinion is going to offend their doctor and somehow weaken that relationship?
Yeah, I want to strongly echo that. I would say in the hematology and oncology community, at the end of the day, almost all physicians are looking to do the right thing and the best thing for their patient. And many times that involves getting an expert or a second set of eyes to look everything over. Even someone like myself, I consider myself an expert in the management of MPNs. Um, but if I have a patient that I'm really struggling about what the next best thing to do is, I have no hesitation about referring them to my other myelofibrosis expert colleagues in the Chicagoland area or even further. I thankfully, as a community, I would say we don't have too much pride. We're willing to ask for help from our colleagues, and I think asking for a second opinion should never be a hesitation that a patient has, and I think it should almost be the expectation that at some point in your journey, if you're a patient with an MPN, it's probably worth seeing a physician that subspecializes in MPNs.
And then so we're slowing down a little bit on questions, but I definitely had a couple that came up that I want to touch on since we have the time. So you mentioned a couple of clinical trials. How do people go about getting on clinical trials?
Yeah, that's a great question. So clinical trials um, are oftentimes, like as I mentioned earlier, they can fall in largely one of three groups: phase one, phase two, and phase three. The first step in my mind is getting linked up with a physician who's an MPN expert that can speak to what trials may be available at their institution or in the area. If a patient is interested in a clinical trial, they would then review a consent form for that trial. They would sign up to be screened, meaning making sure that they meet all of the eligibility criteria. So let's use an example. Many of the studies I mentioned had a very specific platelet count that was needed to be on study. So someone screening may be checking another blood count and making sure that their platelets fall within the range that would allow them to go on a study. So there's the screening period. And if the patient meets all the criteria to go on study, they are then enrolled, meaning they officially are then on the trial and can start receiving the drug that's being offered through the trial.
And then one more question that I had that I think is just kind of a good learning opportunity for the community. So most of these trials are looking at reducing spleen size, but when we talk about myelofibrosis, this is a disease of hematopoietic stem cells, which are housed in the bone marrow. So I feel like there can sometimes be a disconnect of why is my spleen getting bigger if I have a cancer that's in my bone marrow? Um, could you kind of explain some of that biology to really help drive home why spleen size is evaluated?
Yeah, of course. So I like to think of the bone marrow as a factory, and the factory makes your healthy blood cells when it's working well. Now, the body has some backup generators that are used very early on in life. So, like when you're a in utero, when you're or even shortly after birth, the liver and the spleen actually make a lot of your blood components as well. As we age, that responsibility is kind of fully taken over by the bone marrow, and the spleen largely becomes an immune organ, meaning it helps to house a lot of the immune fighting cells and those sorts of things. Now, in patients with myelofibrosis or other MPNs, certainly because the bone marrow, the factory, has parts that are scarred down, the spleen tries to pick up the slack. It starts to kind of go back into its old backup generator mode and starts making these blood cells again. As that happens, though, the spleen starts getting bigger. And there's not a lot of room for a spleen to grow before you start feeling the symptoms of it because it sits next to the stomach, it sits in the abdomen. So that's kind of why enlarged spleens are frequently seen in MPNs.
That's a really good explanation, probably one of the best I've heard. Um, all right, we do have one more question that came in. Um, so is hydroxyurea a good option for ET or early pre-myelofibrosis? No increase in spleen yet or additional symptoms, but I do have a high platelet count. So just again, looking at some of this early evaluations.
Yeah, so for ET, we actually use, it's not just the platelet count alone that determines what needs to be done. So for ET, there are risk scores that we use to try and assess what is the risk of a patient developing a blood clot, which is the major complication related to ET. So these scores are called the IPSET or IPSET-R. And in general, if you have a JAK2 mutation, you're at higher risk of developing a blood clot. If you've had a previous blood clot, you're at risk. If you're over the age of 60, or if you have cardiovascular risk factors, so things like diabetes, high blood pressure, et cetera. So in any of those patients, typically we aim to use what's called cytoreduction, meaning a drug that's going to help to reduce the platelet count. And I'd say the most common ones we use is hydroxyurea or interferon. I do want to underscore there are patients with ET who have a high platelet count that don't need to be on a drug to reduce that platelet count. If they don't have any risk factors for blood clots beyond that, they don't necessarily need to have a normal platelet count. Now, when you talk about pre-fibrotic myelofibrosis or cellular phase myelofibrosis, so myelofibrosis where blood counts are high, the rationale for reducing that platelet count to normal is even less. Like there's really no data that support strongly that you need to try and get someone's platelet count down if they have myelofibrosis. So if someone has a high platelet count with myelofibrosis, who otherwise doesn't have risk factors for clots, they don't have other symptoms, et cetera, they don't necessarily need to be on hydroxyurea. Of
Yeah,
course, each case is kind of individualized. And like I said, there are a lot of things that factor into it, your other medical conditions, what symptoms you have, previous blood clots. So definitely not a one size fits all approach, But I would say there needs to be a good reason for why someone is on a drug to reduce the platelet count if they have ET or if they have early myelofibrosis.
And to the individual that asked this question, I do want to point out I did a webinar a couple weeks ago with Dr. Abdul Rahim Yaqub, where we did focus on really it was a conversation about have early intervention for myelofibrosis. So this was low, so stage 0 or stage 1 or pre-myelofibrosis, and we talked about potential treatment options for those individuals. So if that is something that you're interested in learning more about, we do have the recording of that event housed on our website. Feel free to send me an email and I'm happy to help direct you to that as well. But looks like we are out of questions and we're also getting a little bit short on time. So I'm going to go ahead and wrap up the question section up here. Um, Thank you for spending your time answering these. You did a fantastic job, and I think this was really informative for everyone.
Thanks so much for having me, and thanks to everyone for tuning in. And yeah, happy to be available as a resource or answer questions as they come up or otherwise.
Wonderful. Thank you. All right. Before we go, I want to highlight the Track My Disease feature and HealthTree Care Hub. So this will become available once you've connected your medical records. The Track My Disease feature provides you with the ability to gain a one-of-a-kind access to your health information, encompassing lab results, genetic profiles, as well as your treatment history, and offering you invaluable insights into your own medical journey. On the screen, I have the link to sign up for the Care Hub, along with the email addresses of our amazing patient navigators who are available to help you create an account and connect your records. I'll also include some information about how to enroll in HealthTree Care Hub in our follow-up email, so be on the lookout for that. And then I'm going to take an extra moment to share something exciting with all of you. One of the most powerful things about our community is how we can come together and make a real change. So right now, we have the incredible opportunity to advance blood cancer research. We're working to power 100 research projects that will help change people's lives here at HealthTree. So if you feel called to participate, you can contribute in two meaningful ways. First, by sharing your medical journey and joining the HealthTree Care Hub registry, because your experience matters and you can help researchers understand patterns that they might have otherwise missed. And second, if you're able, through a donation and sharing this fundraiser with your family and friends. All of donations will go directly to funding this research. So it is greatly appreciated and your money is going to a good cause. In our follow-up email, you'll receive links to join HealthTree Care Hub as well as to donate. Thank you all for being an integral part of our community, as it is our goal to make a meaningful change in people's lives through this initiative. Um, as you leave, you will have access to that survey that will help us come up with some more events. We do have some events planned for the new year, but we love hearing people's feedback as well as topics that the community is actually interested in. So when you hop off, please take the 2 to 3 moments that it takes to complete that survey because it really does help us. And finally, I just want to say thank you all for helping us build our myelofibrosis community. Thank you, Dr. Patel, for sharing with us today. That was incredibly insightful, and we rely so heavily on specialists like you to share your time and really share with our community. So I can't thank you enough. Um, I have my email attached to this slide, so please don't hesitate to reach out with any questions about HealthTree or any of our programs, or even just to talk to me. I'm in this role because I like hearing about people's experiences and I want to figure out what I can do and what we at HealthTree can do to really help this community. I appreciate you all and I hope that you have a great rest of your day. And I hope to see you at another webinar soon. Bye.
Thanks again. Have a good day, everyone.